Hello and welcome to the fifth module of PHM 613. For this class, we'll be discussing payment and quality. There are three learning objectives. The first is going to do a brief description of the history of quality in the US, a very brief description. Then, secondly, I'm going to introduce some state and federal policies that are related to payment and quality improvement. And then finally, I'm going to introduce a concept of pay for performance in the US healthcare system. So, for the second and the third objective, I just want to say right off the bat that is going to be very, very foundational information about the policies as well as what pay for performance is and the different programs under the pay for performance. This is to say that I will not be going in depth into these policies or into the P4P programs, just to you know have that clearly stated. So, beginning with the history of quality, we need to first of all kind of understand or kind of explore what we say when we mean when we what we mean when we say quality, and that depends a lot on from whose perspective that you are looking at it. From the patient side, what quality is seen as is goes beyond just the efficacy of the treatment, or even those very very technical sides of uh, healthcare services. The patient's perception of what is good quality goes way beyond that. Is that looking at into the attitude of healthcare professionals, for instance, their perception of how they are being treated, whether they're being treated with respect to dignity, looking at things like the wait hours or how easy it is to get to the clinics or to the hospitals, or even things like how easy or how manageable or the prescriptions they have to take is. So those are all the things that patients look at when they are thinking in terms of quality. And one way that patients' perception of quality is is assessed, is through the patient satisfaction surveys that, if you guys remember, you get that generally after every visit to the clinic, whether it is, inpatient or outpatient. So that is one way that quality is being evaluated from the patient angle. Then, from the clinician side of it, perception of what quality is a bit more objective, in the sense of it's being looked at as adherence to evidence-based practices. So when we say evidence-based practices, we are not just looking at research, the evidence that research has been able to present, but it's looking at it in terms of, okay, what is the research that came out, and how has this research been implemented in clinical settings? Because research very much happens in a controlled environment, but in clinical work, in clinical settings, there are a lot of things that are not controlled, and you just don't know what's going to happen. So evidence-based practice is seeing how outcomes in research get implemented in a real world setting, and how those outcomes, what comes out of it. So that is what we say when we that's what we mean when we say evidence-based practice. So, in the US, quality has not always been associated with payment. There have been more or less like two parallel lines that have not been intersecting. People are either looking at quality, or they're looking at payment. It wasn't something that were looked at, together. But this was before 2003. But after 2003, there are two major events actually that happened that kind of changed, how quality gets evaluated or gets, assessed, whereby quality is being seen from the lens of how, payment is becomes very much intersected with quality. And that happened in 2003. And one of the events was the report that was published by the Agency for Healthcare Research and Quality. And this report kind of looked at health disparities and looked at it from the lens of healthcare quality. And then the second event was the law that George W. Bush signed into act, or sorry, the act that was signed into the law. That was the Medicare Modernization Act. So this is a link to it if you want to know more about this act, and a lot more information if you're interested in that. So what the act did was that it's kind of empowered the Center for Medicare and Medicaid Services to launch a couple of programs and a couple of incentives to help to kind of get the U.S. healthcare system on the track of quality improvement. And some of the initiatives and the organizations that were launched, were geared towards educating, training, and assessing outcomes as a way of measuring, what's going on with quality. More or less, like quality improvements, innovations. Those were something that the CMS did, following the enactment of the law. So, going right into learning two. So there are a couple of federal policies that have looked at, payment and quality, kind of the intersection of that. And a lot of what I'm going to kind of introduce here is going to be federal laws. There is a state law that was done by the state of Maryland, and this was before 2003, when the Medicare Modernization Act came into effect. So the state of Maryland, established a permanent healthcare commission, and that was restricted to Maryland. However, other policies were more national. They were more federal level policies, and those are what we have here. So this is just to let you guys know that these policies exist. You can click on the links to learn more about the policies if you want to, because there are quite a number of them. Just to let you guys know, these are the policies that exist, and the reason they are, geared towards quality improvement, and is tied towards the payment that hospital services receive for that. So there's some of, the way they had the ones that was enacted in 2006, the Tax Relief and Healthcare Acts, and then you had the 2008, with the American Recovery and Investment Act, and you had the High Tech Act. There's the Health Information Technology. That bit was a part of the American Recovery and Reinvestment Act. And then you had 2010 with ACA. There were a couple of other ones that happened that came along with ACA. In 2011, you had the Physician Quality Reporting System, and then you had the accountable costs organization, which I'll talk about later, and that happened in 2011. And in 2012, we had the Medicare Access and Chip Reauthorization Act, MACRA. So I'm going to talk about the ACO and MACRA just in a little bit more detail. So with ACO, it was kind of built off an existing policy of the CMC rather, CMS, yeah, CMS. There was an existing policy that was under the CMS called the Medicare Waiver Project. So the Accountable Act organization was basically built off on that. So what this waiver project did was that it was a way of testing innovations that were geared towards improving access and quality, while simultaneously lowering healthcare costs. So there were a couple of these programs that patients had to apply to become a part of. And one of the advantages that those innovations had was that there were some services that were covered under those projects that were not covered under the Medicare status at the time. So those are some of the benefits that came from that project. So COC improved upon that. You can learn more about that. Right now, there are several hundreds of COCs in the US, all operating in different states and under different projects and different innovations, which you can learn about when you click on that. So with Macra, basically, it's another program that was built off an existing program. So, just like CSO was, MACRA was more or less like an improvement in an existing policy. So, and that policy was a sustainable growth rate, state two. And that was a program that basically catered to physician payment. So with the program, the SGR, what it did was that it had a formula by which doctors were paid on the services that they gave to Medicare patients. So MACRA was a replacement for that. So what MACRA did was to take away the SGR formula, and then there was a introduction of two payment options that had the merit-based incentive payments and advanced alternative payment models. So again, you can click on this to learn more about it. In this class, I'm not going to dive into talking more about them. But let's say if your assignment has you saying, having to discuss them, and what you read is not making any sense to you, do let me know so that we can discuss that. And I would, always make multiple videos or subsequent videos if that would help you understand. But for now, this is just to introduce what these policies are so that you know that they exist. So now we get into pay for performance. Um, Pay for performance, basically, it's just like accumulation of everything I've said before, trying to tie payment and quality improvement as a way of incentivizing healthcare providers to up their services, the quality, both on the patient perception angle as well as theirs, as a way of trying to, if you do, if your quality improvement metrics are coming off saying that you're doing very well, then we either pay you more or we don't deduct from the payment that you would have already gotten. So that is, is a way of kind of summarizing what pay for performance is. So this definition of pay for performance, and this is from Pope et al. 2005. It says that pay for performance is the use of incentives to encourage and reinforce the delivery of evidence-based practices and health system transformation that promotes better outcome as efficiently as possible. So basically, we have from the patient's angle of what quality is, and from the provider angle of what quality is, and trying to make sure that both perceptions of quality are met as much as possible. And those, getting them is tied to either there's an incentive for what providers get, or there is some kind of penalty for not meeting those. So P4P comprises a number of payment modules that have financial incentive or disincentive attached to them, and whether providers are getting those incentives or losing payments depends on how they are performing on a number of metrics. So there are specific quality metrics that are used. So P4P utilizes a pay for system, a pay for service system. It is a way of kind of nudging healthcare providers towards what we call value based care, and can click on this to learn more what value-based care. And what it does is that there are specific metrics that is used to evaluate whether quality outcomes or performance outcomes. So those payments or those systems are tied to those metrics. So when we say value-based care, we are looking at it from multiple lenses. We're looking at it, let's say, for on the patient's angle. We're looking in terms of lower cost and better outcomes in terms of healthcare outcomes. From provider, we could be looking at it from higher patient satisfaction rate in terms of those patient satisfaction surveys that are returned and how those happen. And then you also have it from the payers, from the suppliers, and from the society. So there are a couple. It's with value-based health or value-based care. It's just looking at it from as many lenses as possible as a way to get the overall healthcare system to be performing well. But of course, this is very much our theory. Whether this P4P is actually, getting what is meant to get is an entirely different conversation. But conceptually, that is the aim of P4P, and that's what we're trying to achieve for the healthcare system. So, for healthcare providers that are participating in Medicare programs, there are some requirements that CMS does have for them as a way of them either to get their full payment, reimbursement of services that gave, or to get a bit extra. So you have a number of pay for performance systems through which CMS does this. You have the hospital-based purchasing program, the hospital readmission reduction program, and the hospital-acquired condition reduction program. I'm going to kind of talk about these three in a little bit more detail, but it's not the only ones that there are. The other one is the patient in hospital inpatient quality reporting, which I'm not going to talk about in this class. So this is a policy from 2003, but all four of them are all geared towards Medicare inpatient admissions. So when you read up on this programs, these policies, a lot of them you're going to find that they are all talking in terms of inpatient admission, so that you understand that these programs that I'm talking about are specific to Medicare inpatient admission. So the hospital VB program, what it does is that it has this reward system for acute care hospitals. This is not inpatient in this case, but it is kind of related. But for the acute care hospitals, basically in trying to, look at it from an inpatient hospital setting. And what the program does, it tries to encourage hospitals to kind of improve their metrics in terms of efficiency of care, what the patient's reported experiences are, and what the safety of the care that is being provided. And one of the ways it does that is in measuring whether your hospitals are adopting evidence-based standards of care or protocols, or if they are, and when they do, there's some kind, these hospitals are being incentivized to improve the patient experience. And when that happens, those hospitals that have been able to improve patient experience by, adopting these evidence-based practices get recognized as, being a provider that that gives high quality care at a lower cost of Medicare, which is always marketing tool for hospitals who are trying to get more patients to come to them. So it is a good thing for the hospitals to get. And then we have the readmission reduction program. Basically, what that program is, interested in is in having fewer readmissions happen with the hospitals, and it tries to achieve this by having the hospitals be better engaged with the patients and have a more robust or efficient care discharge plan, so that you want to make sure that when patients leave your hospital, when they're discharged, they're not going to come back for the same thing that they have been discharged for, because it can be quite expensive for the healthcare system to keep treating the same condition again and again for the same patient. So it's a way of reducing, instances of readmission happening. So that is the whole aim of the program. So and from 2012, hospitals, were required to reduce. So hospitals who were reporting excess readmission, we're kind of penalized by having payments, reimbursements to them being reduced. So they end up not getting their full amount of money, which is a penalty or disincentive for the hospitals who are having this very high readmission. Then finally, the hospital acquired condition reduction system program rather. So what this program is interested in is in reducing the rates of hospital acquired conditions of hospital acquired infections, which you can read more here. I don't know what happened. Okay, which you can read more there. So, what hospital-acquired conditions or infections are some infections of this conditions that a patient gets that happened while they're in care of the hospitals. I'm going to use an example. Let's say a patient comes in for surgery on their throat or something like that, and while they admitted to the hospital, between the time they get admitted and the time they get discharged, they suddenly acquire an infection. Let's say they acquire a UTI. That becomes a hospital acquired infection, because at the time they got admitted, they did not have this infection or this condition, but by the time they were being discharged, they had that. So it's just kind of an indication of some quality needing to be improved while the patients are in the system. So how CMS treats this the program is by trying to kind of does it in a scoring system. It has this thing called the total hack scores, and they are weighted. So you have a number of quality specific quality metrics that hospitals get scored in. So at the end of all the score, they are weighted, and then that then determines which total score a hospital gets. So for hospitals that are greater than 75th percentile, they have 1% of their payment or their reimbursement reduced, so they only get 99% instead of 100%. So this is one of the ways that CMS tries to kind of get hospitals to be more conscious of performance of quality. So that's where we end for today's class. If you have any question that is related to the lecture or any of the materials for this course, do ask it, and I will answer the question. Do have a lovely day. Bye.